Hello, my name is Valencia with a spoon. Today we will be doing a physical exam. Do I have your consent? Starting with cranial nerves. Cranial nerve 1, olfactory, is a sensory nerve. And I'm going to ask the patient to close their eyes and occlude one nostril. Occlude one nostril. What do you smell?
Alcohol.
What do you smell?
Alcohol.
Okay. Cranial nerve 1 is intact. Next, we're going to move to cranial nerve 2, which is our optic, and we'll be checking it using the Snellen chart, the confrontation test, and we'll be performing a fundoscopic exam. Snellen chart, normally the patient will hold the chart 6 feet from their face. I'm going to ask the patient to cover one eye and read the smallest line that she can see.
LTFPH. LTFPH.
Patient was able to read the 20/20 line. Next, we're going to do the confrontation test. So I'm going to ask the patient to stand up and cover her right eye, and I'm going to cover my left. Tell me when my fingers come into your field of vision.
Now.
Okay, do the same thing with the other eye. Tell me when.
Now.
Okay. Next, we're going to be doing the fundoscopic exam, and I'm going to come in lateral.
Sorry.
And what we're looking for here is the red reflex, which I did see is the light bouncing off the retina. And if it was absent, we would be concerned for cataracts or artificial eye. We're looking at the arteries to veins should be at a 4:5 ratio. We're looking at the optic disc, which should be a yellowish orange color. Margins should be sharp. Inside is the physiologic cup that should be no greater than 2/3 of the disc. We're looking at the retinal background for perfusion and any AV nicking or cotton wool patches, which she did not have. And we're also looking at the fovea and the macula for any degeneration. When I saw she had a nice bullseye, which is normal. Next, we're going to move to cranial nerve 2 optic, which is sensory, is intact. We're going to move to cranial nerves 3, 4, and 6, which are motor. Cranial nerve 3, oculomotor. Cranial nerve 4, trochlear. Cranial nerve 6, abducens. We're going to start off with the 6 cardinal fields of gaze. Going to ask the patient to follow the object with only her eyes. Okay, and I did not see any lig lag or nystagmus. Next, we're going to check for the corneal light reflex using the pen light. Just going to shine a light on the bridge of her nose. And the reflection bounces off of each eye exactly at 12 o'clock, which is what we want to see. Next, we're going to do the cover and uncover test. Going to cover the patient's eye for at least 30 seconds. And what I'm checking for is any deviation of either eye. Okay. And there's no deviation noted. Next, we're going to move to the perla, which means pupils are equal, round, reactive to light, and accommodation. Her pupils are equal, round. They're about 3 millimeters. Next, we're going to check for reactivity to light. No, it's bright. Okay. So when I shine the light in her left eye, it constricted. And then when I shine the light again, her right eye constricted as well. And that's what you want to see. And you would do the same with the opposite eye. Cranial nerves 3, 4, and 6 are intact. Next, we're going to move to cranial nerve 5, which is our trigeminal, and it is sensory and motor. Testing the sensory portion using a sharp or dull object. Can I see your hand? This is sharp. This is dull. Can you close your eyes?
Sharp. Dull. Sharp.
Okay, could you move your hand?
Dull.
Try it again.
Sharp. Dull. Sharp. Dull.
Okay. The sensory portion is intact. Next, we're going to move to the motor portion. Going to ask the patient to move her jaw from side to side. Okay. Palpating the temporal and the masseter muscles. Can you clench your teeth? Okay. Everything is symmetrical. So cranial nerve 5 and also with the trigeminal, we would do the corneal reflex, which I would take just a light piece of cotton and put it against the cornea, which would elicit a blink reflex. But for the purposes of this exam, we're not going to do that. Moving along to cranial nerve 7, which is facial, which is also sensory and motor. Testing the sensory portion, I'm going to place a substance on the anterior 2/3 of the patient's tongue. Okay. What do you taste?
Salt.
Okay. Moving along to the motor portion of this nerve, gonna ask the patient to raise their eyebrows. Okay, puff out your cheeks. Show me your front teeth, bottom teeth. Okay, give me a big smile. All right, everything is symmetrical. So cranial nerve 7 is intact. Next, we're going to move to cranial nerve 8, which is acoustic, and it is sensory. Starting with the whisper test, I'm standing 1 to 2 feet away from the patient. Gonna ask her to occlude one ear and tell me what she hears. Occlude one ear for me. 99.
99.
Okay, do the same thing with the other ear. 08.
08.
Okay, moving to the Weber test using the tuning fork. What you want to see is the sound lateralizing to both ears. If it lateralizes to the affected ear, it's conductive hearing loss. Unaffected ear, sensory neural. So just tell me what side do you hear the noise on?
Both sides.
Okay. With the Renee test, again using the tuning fork, we're checking air conduction with bone conduction, and air conduction should always be greater than bone conduction, and it should be at a 2-to-1 ratio. It's going to remain the same with sensory neuro, but bone conduction will be greater than air conduction if the patient has conductive hearing loss. So what I'm going to do is hit the tuning fork, place it behind her mastoid process. She's going to tell me when she can't feel it. Put it outside her ear, and she's going to tell me when she can't hear it.
No.
Okay. So cranial nerve 8 is intact. Next, we're going to move to cranial nerve 9 and 10, which is glossopharyngeal and vagus. Those are both sensory and motor. We're going to start off with the sensory portion by placing a substance on the posterior 1/3 of the patient's tongue. Can you open it? Okay. What do you taste?
Salt.
Okay. For the motor portion, gonna look inside your mouth and say "ah" for me. Okay, say "ah." Okay. What I'm looking for is the uvula, making sure that it rises and falls midline, which it does. We're also checking for swallowing and phonation, and we would check the gag reflex, but for the purposes of this exam, we won't. Moving to cranial nerve 11, which is motor, checking spinal accessory. Gonna check her resistance by asking her to shrug her shoulders against my hand. Okay, push against my hand. Okay, 5 out of 5, good strength. Cranial nerve 11 is intact. Moving to the last cranial nerve 12, hypoglossal, which is motor. Gonna ask the patient to stick out her tongue. Put your tongue in either cheek. Okay, everything is symmetrical. That concludes the cranial nerve portion of the exam. Next, we're gonna move to the HEENT and pulmonary and thoracic part of the exam. So starting out, just checking the patient's hair. I'm looking for texture, moisture distribution, any signs of hair loss, which I do not see. I'm also looking at the scalp for any dryness, any masses, lesions, which I do not see as well. Skull is normal, cephalic, and without trauma. Give me a big smile. Okay, face is symmetrical. Next, I'm going to palpate her paranasal sinuses. Okay. Sorry. Okay. Next, I'm going to go to the TMJ muscle, and I'm going to ask her while I palpate to open and close her mouth. And I didn't hear any clicking, which is normal. Next, we're going to move to the ears. We're going to check in the pinna and the auricle and the mastoid process. We're looking for any redness, any swelling, lesions, which I do not feel. I'm going to palpate behind her mastoid process, and I'm going to ask her if she feels any tenderness.
No.
Okay. If she did, that would be otitis media. Next, we're going to do the tug test. With the tug test, I'm just manipulating the auricle, pinna, and the tragus. Checking for any tenderness. Any tenderness?
No.
Okay. If she did have any tenderness, that would be otitis media. Next, we're going to use the otoscope, and I'm just going to look inside her ear. Okay. Pulling her ear up and back. Okay. When I was looking, I didn't see any redness, any swelling, any exudate drainage. The tympanic membrane was pearly gray and translucent. It didn't have any perforation bulging, which you don't want to see. On the left side, the cone of light was at 7 o'clock. On the right side, it would be at 5. You can also check for the obstacles and the landmarks, such as the short hand of malice. And like I said, you would look in the same ear, you're looking for the same thing. The cone of light would just be at 5 o'clock on the right side. Next, we're going to move to the nose. And what I'm going to do is I'm going to take the otoscope and look in her nose to make sure that her nasal mucosa is pink and moist. And I'm going to also view her turbinates. So can you lean your head back for me? Okay. Nasal mucosa is pink and moist. Turbinates, I was only able to see the middle and the inferior one. The superior one is not viewable, and that's normal. Next, with the checking for the septum to make sure that it's mid-line, just gonna trace down her nose. Okay, and it is mid-line. Next, I'm gonna check for patency. I'm gonna ask the patient to occlude one nostril and breathe through the other one. Okay, do the other one. Okay, her nares are patent. Next, we're going to move to the mouth portion. And I'm just gonna use the pen light to look at her mouth. I'm looking at her lips, her gums, her buccal mucosa, the roof and the floor of her mouth, teeth, tonsils, and oropharynx. Okay. Okay, lips are pink and moist. Gums are pink and moist. I see no signs of swelling, redness, or bleeding. Tonsils and oropharynx are not red or enlarged. No white patches on the roof of the mouth, which could mean leukoplakia. So everything is normal with that exam. Next, I'm going to move to the neck portion, and I'm just looking at her neck for any lesions, any looking for symmetry and shape. I'm making sure that she doesn't have any obvious signs of goiter or tracheal deviation, and she does not. Next, I'm going to palpate for a tracheal deviation. So I just take one finger, put it in her sternal notch, and then take my other finger and just trace up to when I feel her trachea. And it is midline, there's no deviation noted. Next, I'm gonna try to palpate for her thyroid gland. Which way you want? Okay. So what I'm gonna do is I'm gonna ask the patient to turn her head to the right and look down. I'm gonna displace the thyroid to the right, and I'm gonna palpate, checking for any enlargement or nodules, which I do not feel. So I'm gonna tell the patient to turn her head to the left and look down. Displacing the thyroid gland to the left, checking again for any enlargement or nodules, which I do not feel. So that exam is normal. Next, moving to lymph nodes. Lymph nodes should be less than 1 centimeter. They should be soft and mobile. If they're hard or fixed or greater than 1 centimeter, that would warrant further investigation. So starting with her submental. Sorry. Submandibular, tonsillar, preauricular, postauricular, occipital, let's see, superficial cervical, okay, deep cervical, okay, supraclavicular, infraclavicular. Okay, next we're going to move to the posterior portion of this exam, looking at the back. So could you, okay, moving your hair. With the posterior portion of the exam, we're looking for size, shape, symmetry, any lesions, scars, or masses. We're looking for abnormalities such as lordosis, kyphosis, or scoliosis, which I do not see. So next I'm going to palpate for any tenderness. Okay, any tenderness?
No.
Any tenderness?
No.
Okay, next I'm going to Check for respiratory expansion at the level of the 10th rib. Take a deep breath for me. Okay, what you want to see is the thumbs separate. That means good lung compliance. Next, I'm going to check for tactile premises in 4 places while asking the patient to say 99.
99, 99, 99, 99.
Okay, and with tactile firmness, it's going to be increased over areas of consolidation, and it's going to be heard greater in the intrascapular area. Let's see. Next, I'm going to percuss. Well, next I'm going to check for a CVA tenderness. Any tenderness?
No.
Any tenderness?
No.
Okay. Next, I'm going to percuss. Okay, and with percussion, you want to hear resonance. Any dullness sound could mean consolidation, and hyperresonance could mean that the patient has COPD or emphysema. Next, I'm going to auscultate for 1 respiratory cycle. And with lung sounds for the posterior portion of this exam, bronchovesicular is best heard in the mid-scapular area. Vesicular sounds are best heard throughout the lung periphery, and any adventitious sounds such as wheezes, rhonchi, or rales should be further investigated. Next, I'm going to check for transmitted voice sounds using egophony. I'm just going to ask the patient to say ee while I listen. Say ee. Okay. And what you want to hear is EE to EE. If you heard EE to A, that could mean consolidation. And with bronchophony, you're asking the patient to say 1, 2, 3, or 99, and any increased sound, or if it gets clearer, that can mean that the patient has consolidation. And the same thing with whisper pictoriloquy. You're just asking the patient to whisper 1, 2, 3, or 99, but you're looking for the same thing. Next, we're going to move to the anterior portion of this exam. Okay. Again, I'm looking at her anterior chest for size, shape, symmetry, any scars or lesions. I'm also checking for pectus excavatum, which can mean retraction or sunken in chest. I'm also looking for pectus cavernatum, which could mean protrusion. And she does not have any. So next I'm going to palpate for tenderness. Any tenderness? Any tenderness?
No.
Okay. Next I'm going to check for respiratory expansion. Gonna ask the patient to take a deep breath in. Okay. And again, you saw my thumb separate, so that means she has good lung compliance. Next I'm going to check for tactile premises. Asking the patient to say 99.
99. 99. 99.
Okay. And I was assessing her respiratory rate. I would say it's 16, normal is 12 to 20. She's not using any of her accessory muscles, so her breathing is unlabored. Next, I'm going to move to percussion. And with percussion over the anterior chest, you should hear resonance. If you hear dullness, you might be over the liver, or you might be over the 5th ICS, which is the heart, or it could be consolidation. If it's a flat noise, you could be over bone. Next, I'm going to move to auscultation. Listening for a full respiratory cycle. And with the anterior portion of this exam, when you're listening to lung sounds, the bronchial, which you won't hear on the posterior, is located between the bronchial main tree and the trachea. Bronchovesicular and vesicular lung sounds will be heard throughout, and any adventitious lung sounds such as rales, bronchi, or wheezing should be further investigated. And next we're going to move to the cardiovascular, abdomen, and peripheral vascular system. Gonna ask the patient to lay down. Okay. And I'm inspecting her precordium. I'm looking for any lifts, heaves, pulsations, scars, masses, or nevi, which I do not see. So we're going to identify and palpate the 6 precordial points. And while I palpate the points, I'm looking for pulsations, lifts, or heaves. Starting with the aortic, which is on the second right. Moving to the second lift, which is pulmonic. Moving to the third lift, which is Erb's point. 4th, tricuspid. And the 5th lift to mid-clavicular line is the mitral. And here is where you can find the apical pulse. And if it's laterally displaced, we could suspect a enlarged heart. Lastly, we have the epigastric, which is right below the xiphoid process midline. And while I palpated, I didn't feel any pulsations, lifts, or heaves. Next, we're going to move to describing heart sounds and where they're found. S1 is best heard over the mitral. S2 is best heard over aortic. S3, 4, and mitral valve prolapse are best heard during, over the mitral area while the patient is laying left lateral decubitus. Split S1 is best heard over the tricuspid. Split S2 is best heard over pulmonic. And mitral regurgitation, murmur, and aortic stenosis are best heard during systole. And to differentiate between the two, you can perform the squat test or the Valsalva maneuver. And I'm going to do the Valsalva maneuver. And what you're listening for is while listening over the mitral area with the diaphragm of my stethoscope, if the sound gets louder, that could mean that the patient has a mitral valve prolapse. If it gets softer or it gets diminished, it could be aortic stenosis. Okay, and I'm going to place my hand on the patient's abdomen and ask her to bear down. Bear down. Okay. All right, next I'm going to listen to the 6 precordial points with the diaphragm of my stethoscope, starting at the aortic. Next, using the bell of my stethoscope, I'm gonna listen to the left lateral sternal border. Starting at pulmonic now. I'm going to our mitral. Okay, next I'm gonna ask the patient to lay on her left side, raise her arms. I'm gonna listen to the mitral area again with the bell of my stethoscope. This is where you can best hear S3, 4, and a mitral valve prolapse. Okay, you can lay back. Now I'm going to ask the patient to sit up, and I'm going to listen to the left lateral sternal border with the diaphragm of my stethoscope. Okay. And exhale completely. And asking the patient to sit up, it just allows you to hear soft murmurs better. You can lay back down. Next, we're going to check for bruits. I'm going to check her carotids in 3 places, and I'm going to ask her to hold her breath when I do it. Okay, turn your head that way. Hold your breath. Okay, you can breathe. Turn your head the other way. Hold your breath. Okay. Next, I'm going to check her radial pulses also with the bell. Brachial. Okay. Abdominal aorta. Renal. Iliac. Okay, and femoral. Okay. Next, I'm going to palpate her pulses, and pulses are graded on a scale 2+ meaning normal, 4+ meaning bounding. Starting with the radial pulse, and you can count for a minute to get the patient's heart rate. Okay, and they're symmetrical, 2+. Gonna defer the femoral pulses at this time. They're located between the groin. Next, we're gonna go to popliteal. Okay, 2+. Next, we're going to go to tibialis. Okay, dorsalis pedis. Okay, 2+. While I'm down here, I'm checking for skin turgor, which she has good. I'm checking skin temp, checking capillary refill. That should be less than 3 seconds. Going back to the upper extremities, checking for the same thing: temperature, skin turgor, and capillary refill. Okay. Describing edema. Dependent edema is just edema of the legs, and it could come from a patient sitting for too long. Pitting edema would be if she did have edema, I could press my finger into it and it will leave an indentation, and based on how long it takes to resolve will be the grade of the edema. Next, we'll move to anasarca, which is just generalized edema, which she does not have. Cerebral edema, swelling of the brain. Pulmonary edema, swelling of the lungs, which she does not have. Next, we're going to move to the abdomen portion of the exam. Could you? Yeah. Looking at the abdomen, I'm looking for any lesions, masses, scars, any nevi, dilated veins. I don't see any. Next, we'll go to bowel sounds. And with bowel sounds, normal is 5 to 35. 5 to 35. And below 5 would be hypoactive. Above 35 would be hyperactive. And any gurgling sounds that I hear would be considered borigny. And I'm gonna listen, following the colon, ascending, transcending, and descending. Okay. Patient has normal bowel sounds. Next, we're going to check for a friction rub, which is located which can be heard over the liver or the spleen, and it's a grating sound that indicates inflammation. It could be from a splenic infarct, a recent liver biopsy, chlamydia or gonorrhea, or splenic infarct or liver tumor. Starting with the liver. Moving to the spleen. Did not hear a grating sound, so negative for friction rub. Next, we're going to move to the venous hum, which can be best heard over the liver, epigastric region, and umbilical region, and it indicates an increase in venous circulation that could mean hepatic cirrhosis. Starting with the liver. Moving to the epigastric, umbilical region. Okay, negative for venous hum. Next, we're going to percuss. And what you want to hear over the abdomen is tympany, over the swing and gastric air bubbles. You would hear dullness over the liver. Okay, next we're going to move to palpation. And before we palpate, if you suspect abdominal aortic aneurysm, which could mean like a marked lateral pulsation, you never palpate. This patient does not have it, so I'm going to start with light palpation. And I'm just checking for any tenderness or any masses. Any tenderness when I do this?
No.
Next, I'm going to move to deep palpation, checking for the same thing. Any tenderness?
No.
Okay. Next, we're going to check for enlarged liver or enlarged spleen. With the liver, it should be about 6 to 12 meters right of the midclavicular line, or 4 to 8 centimeters mid-sternal. And what we're going to do is percuss. So what you would do is go from tympany, stop when you feel dullness, go from resonance, and stop when you feel dullness. So going from tympany to dullness. Okay. Okay, and you would stop when you hear dullness. Next, I'm going to try to palpate the liver, placing my hand under the patient's back for support. I'm going to ask her to take a deep breath in. I'm going to try to palpate the liver, which I don't feel, but if you did, you would want to make sure that the edges are sharp and smooth. Next, we're going to move to the checking for an enlarged spleen. So what you would want to hear is tympany and trough space, and the spleen is between the 9th, 10th, and 11th ICS, posterior to the mid-axillary line. And so what you would do is, again, place your hand under the patient's back for support. I'm going to ask her to take a deep breath in. Trying to palpate the liver, which I cannot. That's a normal finding. Next, we're going to move to abdominal reflexes. And the upper portion is controlled by T8, 9, and 10. So I'm going to lightly stroke towards her umbilicus. Okay. The bottom portion is controlled by T10, 11, and 12. And what you want to see is an umbilical deviation towards the stimulus, which means everything is intact. Next, we're going to move to appendicitis, checking for appendicitis. So if the patient comes in with right lower quadrant pain, there are tests that you can perform to confirm appendicitis, starting with the psoas test. I'm going to try to lift the patient's leg up. Any pain in the right lower quadrant? No. Okay. Doing the obturator. Gonna rotate internally and externally, rotation of the hip to see if she feels pain in the right lower quadrant. Any pain? Okay. Checking for roving sign. That is pretty much referred pain. So I would palpate in the left lower quadrant and she would experience pain in the right lower. Any pain in the right lower quadrant? Okay. Rebound tenderness is pretty much, I'm gonna palpate in the right lower quadrant, and when I release, she would feel pain. Okay, any pain?
No.
Okay. Negative for appendicitis. Next, we're going to move to cholecystitis, which is a inflamed gallbladder. So I'm going to put my thumb over the subcostal margin. I'm going to ask the patient to take a deep breath in. Any pain when you took a deep breath in?
No.
Okay. So she did have cholecystitis. When she took a deep breath in while I was palpating, she would have felt a sharp pain, which she didn't, which that means it's negative for cholecystitis. Next, moving to the musculoskeletal and the neuro portion of this exam, starting with range of motion. Okay, so this is flexion. Flexion. This is abduction, adduction. With the wrist, this is flexion, extension, radial deviation, ulnar deviation. Elbows, flexion, extension, supination, pronation. With the shoulders, you have flexion, you have extension, you have circumduction, you have internal rotation, external rotation. With the neck, you have flexion, extension, rotation to the right, rotation to the left. You have a right lateral band, left lateral band. With the spine, you have flexion, extension, rotation to the right, rotation to the left. You have right lateral band, left lateral band. With the hips, you have flexion, extension, abduction, adduction, internal rotation, external rotation. With the ankles, you have, let's see. With the ankles, you have exversion, inversion, and with the, you have dorsiflexion, plantar flexion, and with the toes, you have flexion, extension. Hope you can see that. Now we're gonna check we're gonna check her knee for any instability. So I'm gonna start off with the varus and valgus test, checking the LCL with the MCL. Let me know if you feel any pain. Checking the LCL. Any pain?
No.
Okay. All right, checking the MCL. Any pain?
No.
Okay, next we're gonna move to the anterior and posterior drawer test. Okay, starting with the, there you go. Starting with the posterior, I'm just gonna try to displace her tibia and fibia, which I cannot. That's a normal finding. Moving to the anterior portion, anterior drawer test, trying to see if I can displace the tibia, and I cannot. So that is normal. Checking for meniscus tears or injury. Gonna bend the patient's leg, and I'm just gonna. Any pain, or did you feel a pop when I did that?
No.
No. Okay. So negative for any meniscus tears or injury. Next, we're going to move to the rotator. Well, carpal tunnel syndrome. Checking the tendons. So what I'm going to do is just lightly palpate again over the median nerve, which is located between the thumb and 2.5 fingers. Any pain, numbness, or tingling when I do that?
No.
Okay. Next, we're going to do Fallon's. Okay. Do your
No.
hands like this. Okay, and when the median nerve is compressed, we're still looking for the same thing. When you did that, did you have any numbness or tingling?
No.
Okay, next we're going to move to the rotator cuff. Okay, could you stand up? Okay, I'm gonna try to palpate her cyst muscles. Do you feel any pain when I do that?
No.
Okay. Next, we're going to do the scratch test and try to scratch under. Then try to scratch on top. Do the same thing with the, okay. Everything was normal. If this was the bad arm, you would see some obvious deviation from what the strong arm could do. Next, we're gonna do the drop arm test, asking the patient to raise her arm to 90 degrees, slowly lower it, slowly, go back. Now slowly lower it. Okay, she has good control. With the drop arm test, if it was positive, when I would bring her arm to 90 degrees, it would just fall. Okay. Next, we're going to move, checking for scoliosis. And so what I'm doing is I'm assessing the height of her shoulders, which are normal. I'm assessing the height of her iliac crest, which is also normal. Could you do your arm like this? Okay, with this, I'm just checking for any winging of the scapula, which I do not see, which is normal. I'm gonna ask the patient to bend down. I'm gonna trace her spine, looking for any curvature as I go down. Okay, and she does not have any curvature, so negative for scoliosis. Next, we're going to check for low back pain. And so what I'm going to do is palpate her paravertebral muscles. Tell me if you feel any tenderness or any pain when I do that.
No.
And I didn't feel any spasms either. Next, I'm going to tell the patient to lay down. Get you lay down. I'm going to check the straight leg raise with the cross strips, straight leg raise. Okay. Gonna bend your knee. Okay. All right. Any pain?
No.
Okay. So straight leg raise was negative on that side, but with the cross straight leg raise, it would be referred pain to the bad leg. Okay. Again, I'm gonna bend your knee. Any pain?
No.
Okay. So negative for the cross straight leg raise. Next, we're going to do deep tendon reflexes, starting with the supinator, which is controlled by C5 and 6. Okay, and you saw the flexion. Moving to the biceps, which is also controlled by C5 and 6. Gonna lightly palpate my thumb. Okay, and you saw a little flexion. Moving to triceps, which is controlled by C6 and 7. Okay, and you saw flexion. Moving to the knees, which is controlled by L2, 3, and 4. Okay. Okay, and you saw the flexion of the toes. Moving to the ankle, which is controlled by S1. Okay. And you saw the flexion of her toes as well. And deep tendon reflexes are graded on a scale of 2+ meaning normal, 4+ meaning hyperreflexia. And her reflexes were 2+. Next, I'm going to check for meningeal signs. Can you lay that down? Starting with Brudzinski's. I'm gonna just try to pick your head up. Okay. And with Brudzinski's, I didn't feel any resistance or any rigidity. Didn't even see involuntary movements of the leg or the knee when I did that. Moving along to Karnick's sign. Picking the patient's leg up, okay, and trying to raise it. Do you feel any pain?
No.
Okay. So negative for Karnick's. Moving along to Babinski's. With Babinski's, you just stroke the foot and you should see flexion of the toes. Okay. Well, I mean extension of the toes. Okay, which you did see. Any in adults, fanning would be abnormal, normal in infants though, but in an adult, if you see fanning, that could mean an upper motor neuron problem. Okay, next I'm going to check for gait or coordination. I'm going to ask the patient to stand up. Okay, and just walk. Do a normal walk. Okay. On the way back, do tandem walking heel to toe. And we're looking for posture. We're looking for coordination. Look for any sway, which you don't have, and she's walking on her tiptoes. Next, I'm going to ask her to walk on her heels. And again, she has good posture, good coordination, so her gait is normal. Next, we're going to move to while she's standing. I'm just going to do the Romberg test. And I'm bracing her in case she sways. A little sway is normal, but too much would indicate an abnormality. And she's good. Okay, I'm gonna ask you to keep standing. Gotta check the pronator drift. So do your hands like this. Okay, and what you're looking for is, okay, there you go. Kind of hold it. What you're looking for, you're watching to see if the patient eventually goes like this, which could mean a corticospinal tract abnormality, which she did not do. So now you can just have a seat. Checking for rapid alternating movement. So I'm going to ask you to do this like this with your hands and your thighs. Close your eyes. Do it as fast as you can. Okay. And we're checking for speed, coordination, which she has, with smoothness of movement. Next, we're going to do finger to thumb. Okay. Close your eyes and do it as fast as you can. Do both hands. Okay. Next, we're going to do heel to hand. Okay. Your heel, my hand. Okay. All right. Next, we're going to check for point-to-point testing. What I want you to do is touch your nose to my finger. Your nose, my finger. Your nose, my finger. Okay, and again, she has good smoothness of movement. No tremors noted when she was doing that. Okay, next, I'm going to place my finger like this, and what I want you to do is take your finger and go like that with it. There you go. Keep going. All right. Next, we're going to do heel to shin. So what I want you to do is just, yeah, and try to do it with the other. Okay, try to go up your shin. Do the other heel. Okay. So all that was intact, and no tremors were noted. She had good smoothness of movement with each test. Next, we're going to move for pain and light touch. Okay. So this will be sharp. This will be dull. Close your eyes for me. What is this?
Sharp. Dull.
Okay. And next, we're going to check for position sense. Okay, so this is up, this is down. Close your eyes. Which way is your finger pointing?
Up.
Which way is your finger pointing? Down. Okay. Same thing with the toes. This is up, this is down. Close your eyes. Which way is your toe pointing?
Up. Down.
All right, so that is intact. Next, we're going to move to checking for graphesthesia and stereognosis. So I'm gonna place the object in the patient's hand and I'm gonna ask her what it is. Could you close your eyes? What's in your hand?
Cotton ball.
Okay, the patient identified a cotton ball. Next, we're gonna check for graphesthesia. I'm just gonna write something in your hand and you tell me what it is. Close your eyes.
S.
Okay, patient identified S, which was correct. This concludes the my physical exam.